Hello, and welcome to this month's OrthoCarolina Live Town Hall webinar. My name is Jason Silva. I'll be talking tonight about knee injuries in active adults. As a reminder, a replay of the talk will be available on social media platforms, Facebook, LinkedIn, and YouTube. At the end, we'll be doing some live question and answers, so please feel free to leave your questions in the comments, and we'll get to as many as we can at the end. Quick introduction. I grew up in Nahant, Massachusetts, a small town up on the North Shore of Boston. I went to Boston College for undergrad and then to the University of Massachusetts for medical school and orthopedic surgery residency. I then moved south to Charlotte for a sports medicine fellowship here at OrthoCarolina, and then returned to Massachusetts for practice for 4 years until returning back to OrthoCarolina in 2017, where I've been working down in our Matthews office as a sports medicine specialty with a sub-interest in shoulder, as well as general orthopedics. So to get into our talk for tonight, again, knee injuries in active adults. So if we're going to talk about active adults, we should talk about epidemiology, sort of who we're talking about. The baby boomer generation, born in 1945 to 1964. So that's going to make those people 62 to 80. One of the first generations to largely embrace fitness and activity, now largely interested in low impact type exercises and activities. Generation X is from 1965 to 1979, so 46 to 61 years old now. One of the first generations really with a big proliferation of youth sports and activities, organized activities. So still embracing team type sports and activities, as well as a lot of home exercises. The millennial generation would follow there from 1980 to 1999, so 26 to 45. We're seeing a lot of proliferation of social and group type classes, studios, and gym type exercises and workouts. Participation rate in fitness sports. So looking here as we're talking about more and more patients remaining active as they're getting older. You can see here 64% of patients in the baby boomer and Generation X generations here continuing to remain active. 70% of millennials from a study here in 2021. Different goals of activities and exercise depending on age. There's obviously physical goals and benefits to continued exercise. Reducing risk of chronic diseases, maintaining strong muscles and bones, weight control. There's a big social aspect of that as well, the camaraderie of group exercise, maintaining a good work-life balance, as well as some group accountability. The mental benefits of continued exercise, continued independence for some of our older patients, being able to remain independent living and self-care. Stress reduction, mental health improvements, we're seeing a lot of benefits for. Various activities for remaining active, team sports, continuing pick up basketball, etc. as you're getting older. Individual sports such as golf, tennis, running, obviously all types of gym type exercises, group type exercises in studio or workout groups around town. Everybody's favorite sport that we're seeing now, pickleball. We previously had a live webinar focused solely on pickleball injuries. As you can see here, pickleball participants by age group. Largest participants, groups ages 25 to 34, as well as 65 plus. So a lot of our older patients are really engaging and enjoying pickleball for the exercise and camaraderie component of that as well. You can see the number of participants over the last few years has really gone up significantly. So now that we know what the activities are, looking at some common injuries that you may see or experience within those activities. The most common things we would see are going to be sprains and strains. So what's the difference? A sprain is an injury to a ligament. Ligament is a structure that connects two bones together. So around the knee, you can see the picture over on the side, what the different ligaments are. That's a grade 1 is more of a stretch type injury to a grade 3 is going to be a full tear of a ligament. MCL or the medial collateral ligament would be the most commonly injured ligament around the knee. That's along the inside part and supports the knee with twisting. The general mechanism of injury is an inward twist of the knee or the knee sort of coming in towards the other one. That can sometimes happen with a twist, could sometimes happen if you get hit on the outside part of your knee. You may or may not feel a pop if that happens. You can have pain with walking or twisting, turning type motions. Occasionally, the knee could feel a little bit unstable with a higher grade injury. Usually that's a clinical diagnosis that we can test by physical exam, by stressing the knee towards the inside, as well as seeing where it may be tender. The general treatment for an MCL injury is going to be a rest, activity modifications, potentially a brace that has some supports on the inside or the outside. For a lower grade injury, the MCL usually takes 2 to 4 weeks until you can have a full return back to athletic activity. A strain is an injury to a muscle. So commonly around the knee, strains or injuries of the quadriceps muscle, which is the big thigh muscles. The hamstring muscles are going to be in the back of the thigh. The gastrocnemius or calf muscles you can injure as well. These usually happen more with quick motions or explosive activities such as jumping or quick change of direction. The diagnosis is usually pain over the soft part of the muscle. You can develop some bruising with higher grade injury and more pain with activities or stretching. Again, strain injuries are usually clinical diagnoses based on the location of the injury or the discomfort with testing. Treatments for muscle strains, a big portion of that is going to be prevention. So make sure you have adequate warm-ups or stretches before beginning activities. Generally, the treatments for that is going to be the RICE method: rest, ice, compression wraps, anti-inflammatories. With higher grade injuries, physical therapy can be helpful, some to help mobilize some swelling, as well as some other treatments to help healing. Tendon ruptures is going to be a little more of a significant injury. So a tendon rupture would be a full thickness tear of a tendon, which attaches the muscle to the bone. So instead of the injury or the discomfort up around the soft part of the muscle, this is going to be down at the lower part of the muscle where it attaches to the bone. Quadriceps tendon tears is where the quadriceps thigh muscles attach to the kneecap. So that injury or pain will be above the patella or the kneecap. Quadriceps tendon injuries usually happen more in our older patients, mid-50s or above. Conversely, patella tendon injuries, the patella tendon connects the kneecap down to the shin bone or the tibia. So that pain or discomfort would be down below the kneecap. We usually see that in some of our younger patients. A mechanism of a tendon injury, again, a quick explosive motion. Sometimes we'll see this in patients playing basketball if they go up for a layup or a rebound. So some quick explosive motions. Could also just be an awkward step or a fall. If you fall and the knee bends backwards or into deep knee flexion, you can sometimes have this injury. The symptoms of this, oftentimes you have an obvious deformity. There can be a softness just around the kneecap, depending on which side the injury is. Can have some swelling that occurs fairly acutely. Inability to straighten or lift the leg. If the muscles aren't attached to the kneecap there's no way for that to straighten. So you wouldn't be able to lift your leg straight up off the ground or the bed. Diagnosis is oftentimes clinical. You can feel some softness around the kneecap. X-ray, like the bottom picture there, can sometimes show an abnormal position of the patella, especially if it's a patella tendon injury below the kneecap. Oftentimes we will get MRIs in order to confirm these diagnoses. If there is a full tear of the tendon, generally you need surgical treatment in order to repair that due to the functional limitations of that injury. One of the most common things we see in and around is osteoarthritis. So studies have shown 9% of the population will have symptomatic arthritis by the time they reach 60 years old. This will increase as we age, oftentimes in females more than males. With arthritis, there's a wide range of severity of symptoms. And there's multiple different kinds of arthritis: idiopathic or wear and tear type arthritis. Inflammatory arthritis is oftentimes things like rheumatoid arthritis. Secondary arthritis due to prior injuries or surgeries. So mechanism of osteoarthritis is generally a wear and tear type injury. So you won't always have an identifiable injury there. Overuse or impact type activities can oftentimes flare up these symptoms. Symptoms that you usually see, this is more the achiness, stiffness, soreness, generally after activities. So oftentimes patients will say they're able to continue participating in the activities, but they'll have that achiness that lingers afterwards. Sometimes you can get a catching or a buckling feeling where that knee is going to grab or potentially feel like it could give out if you have some rough areas of cartilage that contact each other. The diagnosis of arthritis is largely from X-ray. You can see things like the space between the bones being narrowed. You can see some bone spurring or osteophytes along the side of the bones there, and the bone will thicken itself a little bit and will darken that you can see on X-ray. The treatment for arthritis is going to be just as variable as the symptoms. So the symptomatic type treatments are going to be rest, ice, or heat, over-the-counter medicines like Tylenol or anti-inflammatories. There is a whole host of topical creams that you can try for some symptomatic effects. Compression braces can give you some support, especially for activities or exercise. Modifying activities that you do, trying to focus on things that are low or no impact, things like walking, stationary bike, elliptical, instead of impact type activities can oftentimes be helpful. Transitioning from singles tennis to doubles tennis can also limit some of those symptoms. The next steps of treatment would be more of an injection type therapy, whether that's a corticosteroid injection or a gel type viscosupplementation injection can oftentimes give symptomatic relief. There's different types of surgery for knee arthritis that depend on the severity of the arthritis as well as other associated things. That could be a knee arthroscopy or a knee scope, where you have two small incisions in the front of the knee in lower grade arthritis, or if there's meniscal issues, ranging up to a knee replacement if you have more severe arthritis like the picture on the screen here. The meniscus is also a commonly injured structure around the knee. The meniscus is a C-shaped piece of cartilage that is the shock absorber between the femur thigh bone and the tibia shin bone. You have the inside or medial meniscus as well as the outside lateral meniscus. You can have degenerative type tears of the meniscus, more of a wear and tear type injury, or you can have acute traumatic type injuries, which usually involves a twisting mechanism or a deep squat or bend with a twist. Symptoms of meniscus injuries can oftentimes be difficult to separate from arthritis. The symptoms oftentimes are pain along the joint line, which is going to be along the inner side or the outer side of the knee. I think about meniscus injuries more with popping, swelling, as well as some of the more mechanical type symptoms like a catching or a locking or a buckling that can indicate a piece of the meniscus is moving back and forth. Some common type tears of the meniscus, there's all different types that you can have, are down below, and the treatments of those are oftentimes a little bit different. Diagnosis, again, is a clinical diagnosis depending on the pain and the location of the tear. Oftentimes you'll have some focal pain when we push there in the knee, as well as discomfort with twisting or turning. An MRI is oftentimes needed in order to truly diagnose a meniscus tear, to help look at the type of tear that it is that can help guide the treatment. Treatment for meniscus tears, symptomatic type treatments, activity modifications, bracing, formal physical therapy to strengthen the muscles around the knee. Injections similar to arthritis can sometimes help more for the degenerative type wear and tear type tears. Surgery may be indicated for the larger type tears, especially ones that have a flap type piece, like the oblique tear there that can be getting caught in between the bones with movement that's going to give you more of the catching or locking symptoms. ACL tear, I know ACL is the big ligament in the middle part of the knee. The mechanism of ACL injuries is usually a plant or a twist, and the function of the ACL is to prevent the shin bone from coming forward. So this is an injury we usually see more in our younger patients. As I mentioned, it's a cutting, pivoting injury, so a plant and a twist, oftentimes a non-contact injury. So somebody could be playing basketball and plant the knee and fall, not necessarily being hit. Oftentimes you will hear or feel a pop with an ACL injury. The knee will oftentimes get swollen fairly quickly within a couple of hours after the injury. You can sometimes feel instability with walking or twisting. Diagnosis, again, is going to be a clinical exam. With the ACL being a ligament or an elastic there, we can usually get a pretty good idea of whether that's injured or not. An MRI, like is shown here, is the confirmation study. Depending on age and activity levels with an ACL injury, that can sometimes be treated non-operatively with physical therapy and activity modifications. for our patients that want to get back to cutting, pivoting, twisting type activities that need surgery in order to fix. You can have fractures in and around the knee. The most common one we would see is a patella fracture or a fracture of the kneecap. Oftentimes that's from a fall straight on the front part of the knee. Usually you would have a deformity or a swollen area. You could sometimes feel a defect around where the kneecap would be. Similar to the tendon injuries, you could have an inability to straighten the leg with movement. X-rays usually is going to give a good diagnosis for that. Occasionally you would need a CT scan or an MRI if there's a question about fracture pattern. Treatment for the kneecap fractures really depends on the amount of displacement or how far those pieces are spread apart. If that's a non-displaced fracture, you can sometimes treat that in a brace and let that heal by itself. A displaced fracture like we have in the picture here would usually need an operation in order to fix. So, quick review of common injuries here in and around the knee. So, please feel free to submit any questions that you may have. So the first question, how does orthopedic research impact practice with sports medicine? Research studies are very educational for us to look at in terms of weighing one treatment versus the other, as well as comparing new technologies that could benefit. So especially trying to manage widespread patient populations, it's an important part here, giving us informed, educated guidance in terms of what the best practices would be. Next question, do you have any tips for avoiding pain while running in the cold? So cold weather here, especially with activities such as running, the muscles are going to tighten up a little bit. So especially getting into that prevention portion of that. So make sure you have adequate stretch and adequate warm up before progressing the intensity of the exercise. So if you are going to be running, make sure you have a good, say, half-mile warm up here at a slower speed to get the muscle stretched and loose before increasing the intensity. Good clothes here to keep you warm with wind, and a good stretching program once you finish. What is the most important thing to do leading up to a meniscus or an ACL surgery? That's a good question. So for ACL surgery, oftentimes we will delay those surgeries for a few weeks even after the injury. In order to optimize outcomes afterwards, to get you the best outcome we can, surgery will often be delayed in order to try to minimize swelling. So that could even include formal physical therapy for a few weeks before surgery. We want to make sure that your range of motion is back to normal before surgery. The swelling is as little as it can be within the knee joint, as well as your quadriceps muscle being as strong as it can be going into surgery. Right after ACL surgery, those are the things that are the most challenging to manage afterwards: swelling, range of motion, and regaining quad function. So the better and stronger those are going into surgery, the better and easier it will be getting those back. Is it normal for my knee to click and pop whenever I bend it? We see a lot of patients here with those same symptoms. So clicking and popping or cracking in the knee isn't necessarily a bad thing. That can be seen with things such as kneecap or patella joint arthritis. So when you're bending it here, especially past 90 degrees, that clicking, cracking, popping. The question for me would be, does it come along with discomfort when you do that? If it doesn't hurt when you're bending it, that clicking, cracking, and popping can be more inflammation, almost like a knuckle crack. So not necessarily something bad, but that could be the indicator of some kneecap arthritis. Occasionally, meniscus injuries could present with some popping as well. So if it is painful when it clicks and pops, something worth getting looked at. If you just notice some crunching, especially when you're going up and down the stairs, standing from sitting, I'd recommend starting with compression wraps and some physical therapy type exercises to focus on your quadriceps muscle. Next question. I'm 76, fairly active in garden. Is there a safer way to get down to the ground to garden on my knees as I grow older? Very good question. So At 76, you could think about having some arthritis coming on in the knee. So I would be careful with that deep knee bend, such as sort of sitting down on your heels. So getting a low step or a low stool that you could sit on while gardening could be helpful. Making sure you're changing positions frequently if you're down, just to avoid any stiffness there in the knee. Making sure you have a padded surface if you are going to be kneeling there, such as a foam pad or knee pads can be helpful. So I'd be careful with trying to stand up from a deep squatted position. Next question. I had ACL surgeries and knee scopes on both knees, and part of my meniscus was removed. I've been told braces and compression sleeves don't allow the knee to move naturally, but they help. Is this true? I think that the braces and compression sleeves can give you some support. As long as the ACL surgeries gave you back a good, stable knee, you don't necessarily need braces in order to return to activities. With having part of the meniscus removed, one thing that you can see is developing some arthritis in the knee, especially the side of the knee where the meniscus was removed. So I would think that compression sleeves can give you some support if you have some achiness or pain, but can't really give you necessarily the stability. So a little bit of a difficult question to answer. I think that compression sleeves can give you some support, but wouldn't necessarily take the place of unstable knee. What can be done with pain from arthrofibrosis on knee following a knee replacement? That's one of the most challenging things that we deal with here after joint replacements is stiffness. So with knee replacements, we try to get the range of motion moving right away. You're able to put full weight on the knee right away, starting with physical therapy. So stiffness there in the knee is a really challenging problem to deal with. So it really depends on how far out you are from the knee replacement. Early on, we try to focus on anti-inflammatory medicines, formal physical therapy to be helping with the range of motion. You can have something called the manipulation under anesthesia, which is a surgical procedure that would generally be done about 3 to 4 months after a knee replacement if the knee is stiff, where we give you anesthesia and we bend the knee trying to break up some of that scar tissue. If the knee is still stiff or arthrofibrotic here beyond that time frame, that becomes challenging to manage and sometimes would require a revision surgery. It depends how limited the range of motion is, would really guide the treatments. I am trying to age well with the knees, but have torn my meniscus in both knees. Are deep squats good to try and maintain range of motion? So a good question, and some of that depends on what the meniscus tears look like. If that's more of the degenerative wear and tear kind of meniscus tears, it's safe to be doing activities as tolerated. The deeper you bend your knee, the more your femur, your thigh bone will compress the back part of the meniscus, which is where the majority of these tears happen. So it's definitely important to maintain motion, maintain strength in the quad muscle. So squats and those things are good exercises for that. I would be careful how deep of a squat you went. So especially with torn meniscuses here, I would try to limit how deep you squat to about 90 degrees. And that may help protect that a little bit more, especially in the posterior or the back part of the knee. Next question. What are preventative measures that an older, moderately active person can take to protect increasingly, quote, creaky knees? Again, a good question that we frequently see and hear, that sort of cracking, creaking, clicking, popping sensation here. The best way to prevent that or manage that is going to be staying active, is going to be maintaining a good full range of motion of the knee, maintaining good quadricep strength, so good thigh exercise program. The VMO is the inner quad muscle. That's one that oftentimes can get a little bit weak, allowing the kneecap to shift towards the outside part of the knee some. So focusing on quad exercises, especially the VMO muscle, may help combat some of that clicking, cracking, creaking in the knees, especially with stairs, with bending or standing from sitting. What are preventative measures a person can take to protect the back of my knees? The back of the knees, or the posterior part of the knees, is sort of a challenging area. It can sometimes be difficult to tell exactly what's causing pain there in the back of the knee. Your hamstring muscles come down and cross the back of the knee and insert below the knee. Your calf muscles come up and cross the knee and attach above. So some of that could be muscle inflammation or tendonitis. Oftentimes pain in the back of the knees can be from the meniscus. If meniscus tears are happening more in the back portion, that can give you referred pain posteriorly. Something we frequently see with wear and tear type meniscus injuries or arthritis is called a Baker's cyst. A Baker's cyst is some fluid along the inside back part of the knee. Sometimes that can be big and noticeable, and you can feel that, especially as the knee gets straight. Sometimes that Baker's cyst is on the smaller side and can still give you discomfort, but may not be able to be felt. Similar to general protective exercises, maintaining range of motion, maintaining good quad strength, good balance strength between quadriceps and hamstring muscles can be important. What are your thoughts on the Jiffy knee surgery? The Jiffy knee surgery, I don't know that much about. That isn't a procedure that I've seen or done. I know that it is a, quote, minimally invasive type of knee replacement. I'm always a little bit careful or hesitant about some of the new, quote, minimally invasive knee replacement surgeries. With those surgeries, you need to get the same implants to the same spot. So minimally invasive approaches, while exciting, sometimes can have challenges in terms of retraction or moving structures in order to get the adequate visualization. How do arch supports in shoes affect knee function? Everything will sort of play into knee pain or knee function there as well. Patients that have very flat feet can sometimes be knock-kneed or valgus alignment of the knee. So arch supports can help to keep the feet or the ankles more neutral, which can help to support the knees as well, trying to eliminate or limit the knock-kneed or the bow-legged portion of that can put some added pressure on the knee. Next question. I am 80. What type of exercise can I do at home to keep my knees strong? A good home knee exercise program that can include squats, lunges, knee extensions, sometimes with low ankle weights where you're just straightening the knee out here, can be helpful. Functional type exercises, balance exercises focusing on balance, especially at 80 years old, can be important as well. So single leg exercises, just standing on one leg, lifting the knee back and forth, can be helpful both for quad strength, but as well as what we call proprioception, or the position of your body in space, that can help keep the legs in general strong. Does loss of strength in a leg due to a knee injury relative to previous strength pre-injury suggest more of a tear than a strain? Injury happened several months ago. It's a little bit tough to tell there for sure. If you're talking muscle injury or a muscle tear, again, those come in 3 different degrees. So types 1, 2, and 3. Whereas grade 1 is going to be more of a muscle strain or a partial tear. Grade 3 would be a complete tear of the muscle. So the higher grade injury within the muscle belly is going to take a little bit longer to recover from. Muscle injuries or muscle strains, whether they're grade 1, 2s, or 3s, are generally non-operative injuries. Those will heal by themselves given good blood supply. So I would have a similar rehab and recovery treatment plan. If the injury was several months ago and you're still struggling regaining some strength, getting in to see a formal physical therapist can be helpful in terms of trying to help with any inflammation within that muscle belly. Next question. Thoughts on supplements like glucosamine, chondroitin, collagen, hyaluronic acid to help strengthen the knee? My opinion on these is that it's not going to make it any worse, but it's hard to tell exactly how much better it's going to be making that. Scientifically, those structures, glucosamine and chondroitin, are parts of the articular cartilage. So the articular cartilage is a soft, spongy part that basically covers the bone that forms the joints. So those are all building blocks of that articular cartilage. The problem is if you take those by pill, in order to have that pill broken down, absorbed, get through the bloodstream to joints, get into joint spaces where there isn't ready a significant blood flow, and then be able to attach to the cartilage is challenging. So I'll usually refer patients and say, hey, try it for 2 or 3 months and see if you feel like it's making a difference. Usually about a 1 month supply will usually be about $20 or $30. So I usually recommend try it for 2 or 3 months and see how it feels. If you feel like it's helping with symptoms, with activity, especially more of that stiffness type feeling, it's not doing any harm. But after 2 or 3 months, if you don't feel or notice much different, then you can try to stop taking them. Hyaluronic acid injections can help to help basically coat over the ends of the bone to help with gliding, and generally are fairly effective with lower degrees of arthritis. What pain relief is there for arthrofibrosis after knee replacement? So that will sort of get back to as well the amount of arthrofibrosis, how stiff the knee is, and how far out you are from a knee replacement. Pain relief options for that, anti-inflammatories, heat generally can help loosen that up in terms of stretching, formal physical therapy for a good stretching exercise program. Topical creams there can sometimes help as well. Next question. How long do injections resolve knee issues before the next step or surgery must be taken? There's all different kinds of injections in and around the knee, and a lot of that depends on exactly what you're doing it for. Is this more of an arthritis problem or question? Is this more of a wear and tear of the meniscus type issue? Exactly how long or how effective injections are going to be is sort of case by case. I would hope that a cortisone steroid injection, which helps with inflammation in and around the knee, I would hope that that would give you some good improvements over a few months. If you have lower grade arthritis here, the viscosupplementation or gel injections can oftentimes give you a little bit longer relief, but I don't feel that those work quite as well as you get to higher grade of arthritis. Again, the gel injections work primarily by coating over the ends of the bone to try to help protect the cartilage, to help with gliding, whereas a cortisone injection is truly an anti-inflammatory. It's not fixing the cartilage problem there. It's just trying to help the inflammation or pain from that. There's other injections such as PRP or platelet-rich plasma that have fairly good effects for some symptomatic knee arthritis. With that, you would have blood drawn, and then in the office, you can have that spun down, and you take out the platelet cells, which are the clotting or anti-inflammatory cells that then get re-injected into the knee. So how long the injections will last, how long you're going to pursue injection therapy before surgery is really a case-by-case basis. If it's more of an arthritis problem, you can try injections, whether it's gel or cortisone, really until they stop working, at which time a knee replacement would be the treatment for that. If you were trying an injection more for a meniscus type problem, I usually would try that once. And if you don't feel like you have significant improvements, a knee arthroscopy to address the meniscus is usually the next step. Next question. Do you have any tips for runners following meniscus surgery to avoid pain or a re-injury? That's a really good question, and something that a lot of patients have questions for. As I mentioned, the meniscus is the shock absorber between the bones. It helps protect the cartilage on the ends of the bone. Wear of the cartilage is arthritis. So the more meniscus you have, the more shock absorbing function that can do, the less pressure there is on the cartilage. So returning to impact type activities such as running after meniscus surgery is allowable. But oftentimes I'll counsel my patients to try to look at some cross training as well. So while I won't tell them that they can't return to running, I tell them to try to incorporate some cross-training things that are low or no impact, things like stationary bike, elliptical, walking here to try to limit some of the impact through the knee, try to limit the progression of arthritis. Next question. I've got pain in my knee if I move it side to side. Also, the outside of my knee is painful to touch. I'm 75 and very active. What are my options? So in that scenario, they're a little bit difficult to tell if that's more of a meniscus problem or more of an arthritis problem. So an X-ray can help us start off with the early diagnosis there. A lot of those symptomatic type treatments, things like a compression sleeve brace, activity modifications, anti-inflammatories, topical creams may help with some of that pain. If it seems more of like an arthritis problem on an X-ray, sometimes an injection can be helpful for that. If the X-rays look good and it's not thought to be an arthritis problem, potentially an MRI here to rule out a meniscus problem would be a reasonable next step. Should you have surgery if you tore your meniscus 15 years ago? Some of that would depend on what your symptoms are. If you've been functioning well and been able to stay healthy and active over 15 years, continuing with a good exercise program, activity modifications, if you've been doing that well for 15 years, is a very reasonable option to continue. If you have more of the mechanical type symptoms, like a catching or a locking or a buckling, that could be an indication for surgery. So the decision on that would really depend on how limited you are with pain, some of those mechanical symptoms, the amount of arthritis that's in the knee here if there has been a meniscus tear for 15 years, as well as the type of the meniscus tear that it is. If it's frayed along the edge, oftentimes you can continue to be active with those tears. If there is more of a flap that's moving back and forth between the knee, I'd be concerned about that staying symptomatic or potentially progressing, for which surgery would be a good treatment option for that. All right, well, thank you everybody for tuning in and attending. Thank you for submitting your questions here. Hopefully this was informative for you. Thank you all for attending our Knee Injuries in Active Adults webinar. And as a reminder, a replay of this will be available on all the social media platforms. Have a good night. Stay active, stay warm. Thank you.